sorry that you can't see me. Stanford has some issues with Microsoft Teams that happens frequently. Sorry for the issues. So thank you so much for inviting me to talk today about spindle cell lesions of the breast in 2025. It's one of my favorite topics to talk about in the breast. And hopefully we'll see what we can learn. I just want to start by saying I know that a lot of people, when they see a spindle cell lesion, sort of like papillary lesions or vascular lesions of the breast, they often get overly excited, and the purpose of this lecture is to keep everyone calm and give everyone a roadmap for evaluating these lesions in a systematic way. They can have a variety of different appearances and elicits a range of a differential diagnosis that's relatively large, but generally defined. And it ranges from reactive to benign neoplasms to malignancies. And sometimes when you're looking at a case, you're not sure which of those three possibilities it is. So we'll sort of talk about working through that. You might be when you get a case for the first time and you see a bunch of spindle cells on a breast core biopsy, you might, have this sort of thought. And you'll start asking yourself questions. Is it malignant? Is this benign or reactive? Maybe I should just throw a bunch of IHC on it, without barely looking at the H&E. Am I even looking at something that actually is the targeted lesion? Because sometimes these lesions can be bland, and breast stroma, has a variety of appearances just normally. So looking up the clinical history and the imaging is very important in starting to answer these questions. Is the material representative? Many of these lesions can be heterogeneous, and depending on your sampling also, and maybe the size of the lesion, if it's a 6 centimeter mass and you're only looking at a small core, it's unlikely that, you're getting a full picture. But if you're looking at like a 1 centimeter mass, then, it's more likely that you are. So asking all these questions is important. And really the most important step, I think, is what is the next step in treatment? And, what information do we need? What information is helpful to the clinicians in order to know what will guide their next step? Can you make a definitive diagnosis based on the material you have and all of the information that you can find? Or is it better to be descriptive and defer to an excision? And hopefully we'll go from this sort of maze-like messed up thought pattern to sort of more of a systematic one based on the differential you can develop based on the H&E and some stains. So just emphasizing the importance of a clinical history for looking at these kinds of lesions. Like, this is a little bit of a different scenario than do you see ADH or do you see calcs on core biopsy, which is a much more common thing that we do as breast pathologists. The patient age can play a factor in terms of what the differential diagnosis might end up being, how the patient presented, were they symptomatic, how long has the lesion been there. Some of these lesions can be there for years and ignored. Other times they can rapidly grow. The location in the breast can be helpful for a subset of the lesions, especially if they're near the nipple or deep or superficial. If the patient has a prior breast history that's relevant, any kind of trauma, including surgery or biopsy, or history of systemic therapy, cancer, atypia, radiation might end up being relevant. And then specifically, what are the imaging findings? How did they describe the lesion? What is the size? Is it multifocal or unifocal? And a basic description of, perhaps a BI-RADS score, if you use that, to sort of show how suspicious they are. So morphologically, you can, when you first look at a slide, you can first assess the spindle cells, and I often group them into two categories: bland versus definitely pleomorphic. Look for mitotic activity, cellularity, which can range from mild to marked, the architecture that's being formed, That includes both sort of the architectural pattern of the growth itself and the lesional contour, whether it's circumscribed or infiltrative. You could also look to see if you see any evidence of fibroepithelial architecture, which might mean you're actually looking at a fibroepithelial lesion instead of a classical spindle cell lesion in the breast. And then there are these morphologic hints that can sort of point you into certain directions. Do you see conventional epithelioid areas, areas of DCIS? Do you see foreign body giant cells, inflammation, necrosis, which can be present in both benign and reactive and malignant things? And it may even be a vascular formation that you can't quite appreciate. Do you see any evidence of vasoformation? And then we'll talk about ancillary studies, of course, this being a spindle cell lesion lecture. But really, like, I generally shape my ancillary studies based on what I'm thinking could be in the differential diagnosis. CD34 and keratins are often really are almost always in the panel of things that I'm going to order when looking at a spindle cell lesion of the breast. And then depending on whether it's a lower grade or higher grade lesion, you could also consider adding on multiple other stains. Often these cases require a panel approach. And there are some more some newly described in situ hybridization, both FISH and RNA-ish targets for specific genes or specific fusions that we'll get a little bit into. So the basic outline of today's talk will be looking at these kinds of lesions. Some of these I'll focus more on than others because more common things being common and more rare things being rare. But this is the general outline of things that we'll talk about. So we'll start with a case. This is a 44-year-old woman with a 2.5 centimeter painless rubbery mass. You can see core biopsies of a lot of fibrostroma with some benign looking epithelium present. When you look at higher power, you can find these areas with slit-like spaces lined by these bland, flat spindle cells. Don't see any red blood cells within the channels themselves. And this is PASH. Of course, breast spindle cell lesion lecture, we're going to talk about PASH. It's definitely the most frequent and common spindle cell lesion of the breast that you see. You can see it in almost the majority of breast biopsies, but often not for that's usually not the reason. It's usually an incidental finding in a specimen obtained for another reason. It's a benign proliferation of myofibroblasts in mammary stroma that's thought to represent an exaggerated response to hormones, particularly progesterone. It could be incidental, like I said, that's usually the case, but alternatively, it can present as a palpable mass that can clinically and by imaging mimic a fibroepithelial lesion like fibroadenoma. You can call this nodular PASH or PASH tumor, mass-forming PASH. Usually PASH is seen in premenopausal women, but it can occur at any age and in men. The lesional border can be circumscribed to indistinct, and non-tumorous PASH is often detected by non-mass enhancement on MRI. So we get a lot of MRI biopsies showing PASH. Here are some examples. Again, these slit-like anastomosing empty spaces, you can see them admixed with terminal ductal lobular units. It more commonly involves the extralobular stroma than the intralobular stroma, but can involve both. Fascicular PASH is what we call PASH when we see increased cellularity, and sometimes the slit-like spaces can become obliterated, as shown in the bottom image, and sometimes the spindle cells may appear larger. You could look at them on high power and sort of wonder about them, but you can in general see the slit-like space, the reassuring architecture and slit-like spaces of PASH. Even if you don't see the slit-like spaces, usually you can look around in the same specimen and find areas of conventional PASH that blends with the fascicular PASH, and it's sort of reassuring. You can see PASH in fibroadenomas. You can see them in phylloides tumors. You can see it in gynecomastia. If you are concerned, you can do immunohistochemistry, and it stains with CD34 mainly, plus or minus. You might see focal Desmin or SMA staining. It's also positive frequently for ER and PR. It should be negative for vascular markers because it's pseudoangiomatous. It's not really a vascular lesion. And PASH does not require treatment unless it is symptomatic. The differential diagnosis includes the related entity of myofibroblastoma. Like I said, you can see PASH and fibroepithelial lesions. Sometimes you get a limited sample and you know that you see PASH and you wonder if it's PASH in a fibroepithelial tumor or not. And you can sort of describe that in your comment. Low-grade angiosarcoma can mimic PASH, and especially more plump PASH can look like invasive lobular carcinoma. Here's an example of PASH in a fibroepithelial lesion. Next case, 55-year-old woman with a 1.5 centimeter slow-growing mass with ill-defined margins. She got a core biopsy, and you see this relatively cellular fascicles of bland spindle cells, higher power. Perhaps there's some fat either at the lesional border or maybe inside the lesion itself. On higher power, the cells themselves look pretty bland. You don't see any mitotic activity, no necrosis, no real atypia. Doing immunohistochemical stains, it's negative for keratin. There's some anemic CD34 staining. I've seen sort of a variety of intensities of CD34, between labs and between clones, but there's some weak positive staining in the background of the stromal cells, more so than the vasculature. Desmin is focally positive, and ER was, in this case, diffusely positive. In this case, we also did an RB, and RB can be sometimes difficult to interpret, and I don't generally rely on it as a marker by itself, but in this entity that we're looking at, a panel approach of these 4 plus or minus RB stains is helpful to establish the diagnosis here. This case shows some loss of RB in some of the neoplastic cells. This is a myofibroblastoma. Myofibroblastoma is a benign tumor of myofibroblasts, first described in the breast, but can arise in other locations. The pathogenesis is understudied, unknown, perhaps hormonal. It's been reported that there have been mono and biallelic 13q14 deletions, which includes the RB1 and FOXO1A genes. Myofibroblastoma is kind of like the mass version of PASH. It's slow-growing, painless, mobile, usually circumscribed. Women and men can be equally affected. You often see it in older patients. It can resemble a fibroepithelial lesion clinically. Average size is 2 centimeters, but there's a wide size range. And here's just some pictures. There will be a couple of pictures of myofibroblastoma because they have a variety of different patterns that have been recognized. The classic form is composed of spindled myofibroblasts arranged in intersecting short fascicles with a background of hyalinized collagen and variable adipose tissue. There really shouldn't be any atypia or necrosis, basically absent mitotic activity. The myofibroblastomas have a pushing border and typically don't entrap the lesional epithelium, unlike PASH, which PASH can involve the intralobular stroma. This being said, it's described as being a classically pushing border, but you can occasionally see some, usually at the periphery, some entrapped appearing epithelium that might sort of make you question the diagnosis. Patterns that have been recognized include a lot of them: epithelioid, lipomatous, myxoid, fibrous collagenous, palisading, Schwannian-like, leiomyomatous, cellular. IHC, like I said, usually you have to employ a panel approach that includes CD34, Desmin, ER, RB. It should be negative for keratin and S100. Important to note that, and perhaps suggested by the case that I showed, not all myofibroblastomas will show staining with this perfect panel results like described in the textbooks, and 1 to maybe even 2 of the stains may be negative. There are CD34 negative myofibroblastomas, so I wouldn't rely on CD34. If it's a negative, I wouldn't rule out the diagnosis. If everything else fits, I would definitely do these other stains as well. Treatment, historically, these have been excised, but that's being called into question lately. I'll get into that toward the end. But myofibroblastomas are benign and they do not recur. The differential diagnosis differs based on the pattern. Here's an example of an epithelioid myofibroblastoma that can mimic invasive lobular carcinoma. You can really get fooled by these. I've personally seen 3 of these cases, and actually all 3 of them were initially thought to be ILC, either signed out that way or caught just before sign out. These can be very, very challenging and just sort of set you up. It's like a trap. They are both ILC and myofibroblastomas are ER positive. They would be ECAD negative. It's really only that, you know, myofibroblastomas are keratin negative, whereas carcinomas are keratin positive. Beware of CD34 negative cases. That can really also throw some sand into the gears. It can mimic PASH or fibromatosis if you don't see the lesional borders. Cellular cases can make you start thinking about metaplastic carcinoma, the stromal component of a phylloides tumor, perhaps nodular fasciitis. Palisading myofibroblastoma can mimic schwannomas. Myxoid myofibroblastomas can mimic neurofibromas or myxoid fibroadenomas. And then there's a variant of myofibroblastomas that can mimic leiomyomas that are called leiomyidous myofibroblastoma. And they show smooth muscle differentiation with staining with often can show staining for Cal Desmond. Here's like, you know, a case that might make you wonder about, you know, schwannoma with the alternating cellular and hypocellular areas. Here's an example of a myxoid myofibroblastoma that could mimic neurofibroma or other myxoid lesions. Next case is a 30-year-old woman with a 2.8 centimeter slow-growing firm spiculated mass in a deep location. We have a cellular with no evaluable epithelium here in this biopsy, fascicles of generally bland cells, and then if you look carefully in one of the other cores, you actually can see that it involves skeletal muscle. You do immunohistochemical workup on it, CD34 and keratin, I've said are kind of like the 2 stains that I almost always include in a workup of a spindle cell lesion. And SMA here shows some patchy positivity, and beta-catenin here shows some nuclear expression. So this is an example of fibromatosis. This is an infiltrative fibroblastic myofibroblastic neoplasm with risk for local recurrence, but lacking metastatic potential. It shows activation of the Wnt beta-catenin signaling pathway. Most of these cases are sporadic, but a minority are associated with familial adenomatous polyposis or Gardner syndrome, which is caused by a germline APC mutation. You can see somatic activating mutations in the gene for beta-catenin or APC. You always see either one or the other, but not both. In cases that are really diagnostically challenging, I've seen people send for sequencing to confirm the presence of beta-catenin mutation. These are slowly evolving firm palpable masses, may have skin retraction, may be painful. Sometimes the patient reports a history of trauma, and imaging cannot distinguish this often from carcinoma because both are often stellate, poorly circumscribed. The average size is 2 to 3 centimeters, but a wide range. So fibromatosis microscopically looks like fibromatosis in other parts of the body with these bland spindle cells and long sweeping fascicles. Shouldn't see atypia or necrosis. Mitotic activity, same, absent to scant. The cellularity can vary. You can have a hypocellular case that's more myxoid with loose stroma, or it can be heavily collagenized. Um, One helpful thing that I find is these nodular lymphoid aggregates that you could see at the periphery of the lesion. These nodular lymphoid aggregates aren't specific to fibromatosis, but they can be seen in a subset of breast entities, and fibromatosis is one of them. Um, Unlike some of the other entities we talked about, myofibroblastoma, uh, the fibromatosis is really characterized by this infiltrative growth that can entrap surrounding tissue like breast epithelium and skeletal muscle. IHC beta-catenin is positive nuclear with nuclear staining in most cases, and it has some caveats, and it doesn't necessarily need to show this to be fibromatosis. There could be some staining with SMA and Desmond, and it should be negative for CD34, keratins, P63, and S100. Just a note, nuclear beta-catenin does not equal fibromatosis. I've seen some trainees, look at a beta-catenin stain and call it fibromatosis, but in breast, uh, nuclear beta-catenin actually is been reported to be seen in metaplastic carcinomas, fibroepithelial lesions of all different grades, as well as scar. So you have to, when you use beta-catenin, it's sort of, sometimes you have to look carefully at the stain itself to interpret it correctly, but then also know, the caveats that come with it. Treatment also, like myofibroblastoma, evolving. Historically, this had been, fibromatosis had been excised to negative margins, sometimes causing some significant morbidity in patients. But now active surveillance is being used in increasing numbers, and other medical therapies have also been tried in selected patients, most commonly tamoxifen, rarely tyrosine kinase inhibitors. Fibromatosis, the differential diagnosis is similar to those of other low-grade spindle cell lesions of the breast, scar, nodular fasciitis, myofibroblastoma, fibromatosis like metaplastic carcinoma, which we'll talk about, and the stromal component of phylloides tumors. Here's some examples of for example, mimicking PASH up here. This kind of looks maybe like the stroma of a fibroepithelial lesion, but down here we see sort of the infiltrative growth that is almost always seen in fibromatosis. Next case is a 27-year-old woman with a tender, rapidly growing palpable mass and overlying skin retraction. Here's the core biopsy. On more medium power, the cells are, it's a cellular lesion, but when you look carefully, the cells are not that atypical. Maybe you see some extravasated RBCs. You do find some mitotic activity. Sometimes these cases can have an abundant mitotic activity, and it can at first be scary, but this is actually nodular fasciitis, which is pretty rare to diagnose in a breast core biopsy, but can happen, and it's important to not forget about it if you don't see it that often. It's a benign self-limited neoplastic proliferation of fibroblastic and myofibroblastic cells. The majority of cases harbor a gene rearrangement of USP6, which is a deubiquitination enzyme. The most common partner is MYH9. It can appear scary because it often presents as a rapidly growing palpable mass with tenderness and skin retraction. Some report a history of trauma. So it could be rapidly growing and be symptomatic, but often they are in the size of 1 to 2 centimeters. They can be larger, and imaging often cannot distinguish it from malignancy. Here's an SMA stain, which is positive. And nodular fasciitis can have can range in appearance from more myxoid to collagenous, sort of depending on the age of the lesion. The cells are relatively uniform, although they may look cellular, and you might see mitotic activity. This microcystic change that happens to the stroma imparts the appearance of this tissue culture appearance. Necrosis is absent. Atypical mites should be absent. Like I said, you can see extravasated erythrocytes, lymphoid cells, hemosiderin-laden macrophages, sometimes giant cells. There's often a circumscription at low power, but then when you look at it on more higher power, you can see it sort of focally infiltrative with the surrounding adipose tissue. Sometimes it can encroach on epithelial elements. There isn't a slam dunk staining panel to do. SMA is patchy to diffusely positive. It's not, you know, outside this context, SMA is not a very specific marker, but combined with the morphology, you know, it's very supportive. It should be negative for keratins, P63, desmin, and beta-catenin. And you can do USP6 FISH, or you could do fusion stamped, or you could do fusion testing to identify a rearrangement of USP6 that is seen in a majority, but not all, of nodular fasciitis cases. This might be important to do, which I'll talk about toward the end. Nodular fasciitis is typically a self-resolving neoplasm. It usually goes away in weeks to months. If occasionally it sticks around, you might do an excision. And when you're making this diagnosis on a biopsy, you know, because now the management of nodular fasciitis has evolved to, we know more about it. We know that it typically self-resolves. If you can make a definitive diagnosis on biopsy, you can spare the patient an excision. And so it may be worth it to, you know, work it up potentially for that USP6 fusion or not, or if it really morphologically and immunohistochemically fits. But nodular fasciitis is known to be prone to misdiagnosis. The rapid clinical growth and pseudosarcoma disappearance often can get misdiagnosed as malignancy. In the differential are metaplastic carcinoma, fibromatosis, PASH, Fallotti's tumors, other myofibroblastic tumors. Next case is a 66-year-old woman. That's all we were told, and it looks like this. And initially, the physician actually, so here on higher power, you could see the spindle cell proliferation, sort of variable cellularity. You can see these more prominent thin-walled vessels here. And as part of their workup, they did a beta-catenin stain and found that there was nuclear beta-catenin. So it's a limited sample, but is this fibromatosis? And that's the question. So I can tell you it's not fibromatosis. It's actually scar. It turns out the patient had a prior reduction. So don't forget scar. Sometimes you have to dive deep into the electronic medical record to find evidence of some sort of procedure. Just remember beta-catenin can be positive in scar. And, you know, we used to, back when fibromatosis was more surgically managed, you know, sometimes get these challenging cases of fibromatosis that had initially positive margins on excision, and then they would go back and do re-excision of margins, and you'd have perhaps residual fibromatosis, but now with superimposed surgical site changes like scar, and differentiating those two things is almost impossible, and you can't use beta-catenin most of the time. So thankfully we get these a lot less, but this was a very challenging scenario. And just remember, beta-catenin does not equal fibromatosis. Next case is a 65-year-old woman with a 2-centimeter mass. Here are some core biopsies. You know, much of the tissue appears to be necrotic, maybe ischemic necrotic, but on the tip of some of the cores here, it becomes more cellular, but still pretty bland looking. And this case actually was initially assessed and done with a pan-keratin, which included AE13 and CAM 5.2, which was completely negative. And only upon re-review with additional staining did it turn out that staining with a high molecular weight keratin like CK56 actually revealed the diagnosis, and this was actually a metaplastic carcinoma. So metaplastic carcinomas, I don't have, that's like its own separate lecture of all we could talk about metaplastic carcinomas, but I'm going to sort of narrow it to the spindle cell, since this is a spindle cell lecture. They are a heterogeneous group of invasive breast carcinomas that can differentiate towards squamous and/or mesenchymal elements, including spindles and other types of differentiation. They can include one metaplastic component, which is most often spindle or squamous, or they can contain multiple. They can also be mixed with classic adenocarcinoma or ductal of no special type. The majority of cases are triple negative for ER/PR and HER2. Often you need a panel of IHC stains to illustrate epithelial differentiation. Here are a list of keratins. Most labs have most of these, but not all. Myoepithelial markers can also be positive in metaplastic carcinomas, and CD34 is basically negative in metaplastic carcinomas. So it's one nice sort of rule out stain you can do. Molecularly, metaplastic carcinomas are heterogeneous. They show complex copy number alterations. They often have P53, RB, and alterations in the PI3 kinase pathway. They actually have more common PI3 kinase pathway alterations in metaplastic carcinoma than in other triple negative breast cancers. And there are differences among subtypes of metaplastic carcinomas. Again, going to focus on spindle cell metaplastic carcinoma. So this term refers to like the high grade version of, which is more common, metaplastic carcinoma. It's the most frequent metaplastic element in metaplastic carcinomas, these pleomorphic spindle cells that resemble a high-grade sarcoma. When you're looking at a case like a high-grade malignancy of the breast, you want to look for certain clues like DCIS or even more epithelioid elements that sort of blend into the more spindled areas. You can see occasional squamous differentiation, both in metaplastic carcinoma, but also you can see focal squamous differentiation in other breast malignancies also. That doesn't necessarily, that we give different names to them and don't call it metaplastic carcinoma if we see focal squamous differentiation in some of them. Spindle cell metaplastic carcinoma is most common in postmenopausal women. P53 mutations are less common in spindle cell tumors compared to other metaplastic carcinomas. Not really helpful on an individual basis, but sort of interesting as a group. They can present with nodal metastases less commonly than IDC-NST, but more commonly than a phylloides tumor, which is often in the differential diagnosis of a metaplastic carcinoma. And just remember, this is like a high-grade triple-negative breast carcinoma, and oftentimes neoadjuvant chemotherapy is what the patient should get, assuming it's not a very small metaplastic carcinoma, which is pretty rare. Usually these are large and present themselves, and it's not subtle. So they want to give neoadjuvant chemotherapy for metaplastic carcinoma, but they wouldn't for other things in the differential diagnosis. Then there's this subtype of metaplastic carcinoma, and it's a little bit confusing sometimes because usually clinicians hear metaplastic carcinoma and they think bad, 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 but there are these rare subtypes of metaplastic carcinomas that show indolent behavior. Fibromatosis-like metaplastic carcinoma is one of them, characterized by bland spindle cells arranged in these short interlacing or long fascicles and embedded in a variable collagenized stroma. There should not be high nuclear grade in this entity. You can see sometimes these cords and clusters of more epithelioid cells that might clue you into the diagnosis, as well as focal squamous differentiation. These mostly have a good prognosis. They can recur locally with less than ideal margins. Distant metastases of this entity are very rare. They've been shown to have relatively flat genomes with frequent TERT promoter and PIK3CA mutations. And it's important to both, as you're evaluating the case, diagnostically rule out or distinguish it from its, more common spindle cell metaplastic carcinoma cousin. That may mean that, you might need to look at, if you have a surgical excision, you might want to look at more of it to make sure that there isn't a high grade component inside it. You also want to explain to clinicians that, this is different than the metaplastic carcinoma that you typically know about. And this entity has been described in a number of review articles. Here's a more recent one about triple negative breast cancers with a favorable prognosis. Illustrating that more, this is the NCCN guidelines for invasive breast carcinoma and deciding on adjuvant systemic therapy after upfront surgery, also applicable to neoadjuvant therapy. And it really calls out these favorable histologic types, ones we know about, like mucinous and tubular and conventional adenoid cystic and secretory, but also rare low-grade forms of metaplastic carcinoma, and they call out low-grade fibromatosis-like carcinoma in addition to low-grade adenosquamous carcinoma, so without adjuvant systemic therapies. So making a diagnosis of low-grade fibromatosis-like carcinoma, it would typically be over-treatment to treat the patient with systemic therapy. Next case, 26-year-old woman with Lee-Fermini syndrome presenting with a 9-centimeter breast mass, and they do an excision, and you get one of these cases where you just have slides and slides of this solid sheets of spindle cells, of variable pleomorphism in the cells themselves, mitotic activity. Maybe you'll see necrosis in other sections, but no real architecture to speak of. You can try doing immunohistochemical stains. This is a keratin, it's negative. This is a desmin, it's negative. This is an S100, it's negative. And this is a case where you luck out and you get a positive CD34. Honestly, that usually doesn't happen, but when it does happen, then it's very helpful because metaplastic carcinomas, like I said, are not thought to be CD34 positive, and phylloides tumors can be CD34 positive. They can also be CD34 negative, so if it's negative, it doesn't help you, it doesn't rule it out. But I'm just going to briefly mention, because this is a spindle cell talk, that sometimes this differential intersects with fibroepithelial tumors, and the stromal component can be in the differential diagnosis of spindle cell tumors if you don't appreciate that the epithelium is part of the lesion, or if there is an epithelium to evaluate. This scenario is more common with more cellular and or atypical stroma, but not always. Sometimes you just get sampling of a core biopsy where you can see that there are spindle cells and you can see that there's epithelium, but you're not necessarily sure that the epithelium is lesional, so you might sign it out descriptively. And then this is the excision of this biopsy, and it's more clear at this point that it's a fibroepithelial lesion. Other times you'll have core biopsies where you have this like high-grade malignancy with necrosis, no epithelium to evaluate, you do your stains, they are not informative, and you just have to sign it out descriptively as a high-grade malignancy, and sometimes you can't favor a metaplastic carcinoma or a high-grade phalloides tumor. It's less likely as some sort of sarcoma that can occur elsewhere in the body. Core biopsy, you're limited to what the sample that you get. These lesions are known to be heterogeneous, so look for those morphologic clues of carcinoma. CD34 can help you, but sometimes it doesn't work. And it's been, we've in the last decade, we've had a greater appreciation that phalloides tumors can show focal keratin and P63 staining. I've seen some cases with even, pretty prominent patchy P63 staining. So just because you have some staining of keratins in P63, especially in a core biopsy, that does not necessarily mean automatically metaplastic carcinoma, and I think you should be cautious in making that leap unless they're really diffuse staining of especially keratins. On an excision, you have more to look at, but you could get one of those cases like I showed you with just sheets and sheets of spindle cells. Really, like, you're looking to see if you see any leaf-like architecture or intracanalicular growth, or even just like some ducts that are inside that look curvilinear that are suggestive of maybe a phalloides tumor. I think the most helpful thing in those cases is to just sample more. That actually probably gives you an answer more than doing IHC, which you'll probably still do anyway. And sometimes you can consider doing it on 2 blocks because, again, these lesions are heterogeneous, both in morphology and even in immunohistochemical staining. I've seen some cases where 1 block is negative and another block is positive. So you still probably have to do the IHC. And then if really these don't work out, then at the excision stage, if you want to still try for a definitive diagnosis, you can do NGS and look for MED12 mutations, which are seen in fibroepithelial tumors and not metaplastic carcinomas. I really like this paper. This is mostly Gregory Bean's paper, where both he looked at a series of cases that were malignant phalloides tumors and metaplastic carcinomas, did CD34 staining, keratin and P63 staining, as well as NGS, and basically was able to use NGS in the presence of a MED12 mutation and or the presence of CD34 positivity to see them in 70% of malignant phalloides tumors, and that included cases that had keratin and P63 staining, some of them, pretty patchy P63 staining. So you can use IHC and NGS when you have these cases that the morphology still isn't cooperating with you despite more sampling. Also, this case has a nice supplemental table where Gregor painstakingly went through all of the prior literature and reports of different genetic alterations in both metaplastic carcinoma and malignant phalloides tumor, and listed them all with percentages. So I kind of look at that table sometimes when I have one of these cases. Also, that paper identified that SETD2 mutations are quite pretty specific for a malignant phalloides tumor in this differential diagnosis of metaplastic breast carcinoma. So SETD2 might also be helpful in addition to MED12. Switching gears, vascular tumors. So the rest of the talk, I'm not devoting as much time to each entity because they're kind of less common or less often in the differential diagnosis. These can be in the differential diagnosis with spindle cell tumors. You can have angiosarcomas with sort of solid growth areas where the vasoformation is not apparent. Also, on the benign side, you can have cellular angiofibromas that look like spindle cell lesions. This case here is an example of an angiosarcoma that can somewhat mimic PASH. Here's a case of a cellular angiolipoma that has some spindle appearing cells. And then the rest of these are just more examples of angiosarcomas, which can show a variety of different appearances, you know, hemorrhage and necrosis in this one. Some of these can resemble carcinomas. And then sometimes you can have these very atypical cells, but still forming channels. So just remember that vascular tumors can be in the differential. So for some cases, you may want to throw on vascular markers. I like ERG, CD31. Some angiosarcomas are negative for CD34, and some angiosarcomas actually can be keratin positive, which can mess you up. Here's an example of ERG positivity. Smooth muscle tumors, not going to talk a lot about this one. You can see smooth muscle metaplasia in a variety of breast lesions, myeloid hamartomas, the aforementioned leiomyomatous myofibroblastoma. Fibroepithelial tumors can show myeloid metaplasia. These are, I think, kind of more common than the two entities we'll talk about. Leiomyoma being the benign one. This is very rare in the breast. It can occur in the skin, nipple areolar area, or deep. Most of them are sporadic, but some of them can arise in association with patients that have a fumarate hydratase germline mutation. It looks like a leiomyoma in other parts of the body with eosinophilic cytoplasm and cigar-shaped nuclei and intersecting fascicles, circumscribed, but the ones that are involving the nipple areolar might be a little more disorganized, as shown up here. These stain for smooth muscle markers, as well as ER and PR. The malignant counterpart of leiomyoma is a leiomyosarcoma, also very rare, kind of seen in the same areas. Most patients are postmenopausal, often a circumscribed mass. Looks like leiomyosarcomas in other parts of the body. Mitotic activity, necrosis, stains like you'd expect it to. These rare tumors are typically treated with mastectomy when they're deep. Superficial ones can be excised typically. You want to rule out a metastasis of a leiomyosarcoma from the gyne tract, for example. And then, of course, a lot of these more rare tumors, part of our duty in looking at the excision itself is often that we have to rule out that, you know, because a leiomyosarcoma and many of these other sarcomas are quite rare, and it's known that phalloides tumors can actually spawn areas of you know, less common sarcoma types. So it could theoretically come from a phalloides tumor. Of note, there's no agreed upon criteria for like mitotic activity or other things like in the gyne tract for breast cases, since they're so rare. Just very briefly, peripheral nerve sheath tumors, schwannomas, similar to other schwannomas seen in other parts of the body. Slow growing, well-defined, mobile, painless mass. You can see cystic change. Same morphology as other sites, positive for S100 and SOX10, negative for CD34, Desmond, ER. Same differential diagnosis for other low-grade spindle cell lesions of the breast. Neurofibroma, similarly, same appearance as other places of the body. Most commonly, these present in the breast in NF1 patients. A superficial location is more common in the dermis or the nipple areolar complex. It has this shredded carrot appearance. There are different variants of neurofibromas. These are positive for S100 and SOX10 in the Schwann cells, positive for CD34 in the perineural and other stromal cells. And of note, NF1 patients, neurofibromas can undergo malignant transformation, so you don't want to miss that. Another case, 27-year-old woman with a slow-growing superficial mass, looks like this, very cellular storiform growth. Here's the immunopanel, and this one is also CD34 positive. But with that kind of characteristic, tightly packed storiform growth. It brings, and superficial location, it brings to mind a certain diagnosis. This is a PDGFB RNA-ish stain that helps to confirm the diagnosis. This is DFSP. This is a superficial, locally aggressive fibroblastic neoplasm that you can see in the skin of the breast. They present as nodular lesions or plaque-like growths. They are excised with negative margins. Occasionally, radiotherapy is used, and occasionally TKIs are used for cases that undergo fibrosarcomatous transformation. These are CD34 positive. And then a newly described marker you can use is a PDGFB RNA-ish, and that can help with the diagnosis. But there's a sort of important caveat in that actually the majority of breast DFSPs, unlike other DFSPs in other parts of the body, instead of having PDGFB, they actually have a alternative rearrangement, including PDGFD. So PDGFB RNA-ish would be negative in those cases, but PDGFD testing, either by FISH or some other method, could help you in breast-specific DFSPs, which is kind of an interesting anatomical, pathological phenomenon. Other sarcomas can arise in the breast, but they're rarer. If a patient has a history of radiation, that's good to know, because you can actually get different types of radiation-induced radiation-induced sarcomas. In addition to angiosarcoma, you can get MPNSTs, you can get UPSs, you can get different types of sarcomas, and then basically you can get any type of sarcoma that can occur elsewhere in the body, but in the breast too. So sort of wrapping up, going to try to wrap up quickly. What's been changed? Like this topic, the name of this lecture is what's going on in 2025, and really the main sort of evolving change is that in management of some of these more benign and intermediate mesenchymal lesions. So the upcoming WHO draft version of the mesenchymal tumors chapter mentions that there's this movement toward increased non-operative management in the setting of good rad-path correlation for some of these entities, or at least no additional surgeries following excisions with positive margins, which in the past we used to chase positive margins for fibromatosis, for example. And fibromatosis also has some updated text. Some of this was in the last version, but some of it's updated, where now we're saying while a primary surgical approach with negative margins was the previous standard of care, margin status fails to consistently correlate with local recurrence rates, and patients can show regression. So now a watchful waiting approach has been advocated and adopted for asymptomatic patients. And there's this specific alteration in codon 45 that appears to portend a higher risk of local recurrence and sporadic fibromatosis, as does larger tumor size and younger age. So a number of factors will probably go into making the decision whether to do watchful waiting or a conservative excision. So historically, looking at breast core biopsies, in the past, I think a lot of the times, we would do like a limited workup because we would know that excision was the next step. You could describe it as bland or atypical, or say it's neoplastic, or call it a malignancy or some sort of sarcoma. It's kind of similar to vascular lesions of the breast, where it used to be the case that we used to excise these almost all the time. So it didn't matter so much the workup and committing or not committing to a diagnosis. But now in 2025, there will still always be these cases that either because of limited sampling or because the immunohistochemistry isn't working the way you thought it would, or you simply don't know what the lesion is, or it's a very limited, tiny focal sampling of something that might be a much larger mass, There will always be times where we have to use descriptive diagnoses, and that's okay. And the next step in those cases is appropriate surgical excision to get a more definitive diagnosis. But it's now kind of with a core biopsy and with some additional ancillary testing, it may be that we now can definitively diagnose some of these entities more commonly, and that really can affect management. So nodular fasciitis, if definitively diagnosed, really should be observed rather than excised. Fibromatosis is, plus or minus observation or surgical excision. I've seen different areas of regional differences about how myofibroblastomas are handled, whether they're always excised or whether they aren't, and then kind of bland vascular lesions. We've also, with good rad path correlation, been able to observe these more often. And really, metaplastic carcinoma is sort of on the opposite end of the spectrum, where, like, if you can make a diagnosis of that, the patient, would undergo neoadjuvant therapy. So that if you can make that diagnosis, it would be good to afford that patient that opportunity. But sometimes you still can't, and sometimes surgical excision is the next appropriate step. So here is, even though it's not a maze, it's more of a schematic thought process of how to approach spindle cell lesions on core biopsy, high versus low grade, throwing in some ancillary testing, and then perhaps arriving at a diagnosis. I will let you look at this by yourself, and here are my references, and thank you, and I'm sorry that I started late and have gone a little over time.